just within time, is from Helmut Reuter, who started off the Ukwanda Rural Clinical School many years ago, but has gone over to the other side in specialist medicine and is a professor of internal medicine at Tygerberg Hospital. Helmut is obviously Herman's brother, and they share a background from Namibia, and has an extensive CV, which I won't go into now because otherwise I'll steal your time, and I'd rather hear from the horse's mouth than tell them all about you. You can add more as you want to. Helmut, over to you.
Okay, good afternoon. Thanks for the opportunity and thanks for the very kind introduction. In medicine, we always start with disclosures. So I'll give my disclosures. Firstly, I was invited by Herman to speak. He said, Ukwanda is about 20 years old. Isn't it time that you reflect on this? Yes. Secondly, my grandmother, maternal grandmother, she was a nurse and she was one of the first to actually work in mental health. My mother was a nursery school teacher and she worked with children with hearing disability. My older sister is an occupational therapist. My second sister is Helga Berger, who just opened this session. She's at UNAM in Windhoek. My wife is an occupational therapist. My brother is Herman. So I will speak about a little bit of the journey to where I'm now in the Department of Medicine. I started off on a very, very singular track to rural health. It wasn't particularly straight and it wasn't particularly smooth, but it was very focused and so it started in Windhoek, and I wanted to, there are two things here that one looks at. Firstly, Windhoek is usually a dry place. Sometimes there's rain and there's abundance and goes green. Second that you see here is the church, the Christ Church. And I want you to just think about the building of a church versus what does church stand for? What is behind church? What is behind belief systems? And that interaction between building and contents of soul. I studied at Stellenbosch, a rural town, sort of Stellenbosch, not completely. Did a rotation at Paul, Opsengani. That I enjoyed. That was good. We learned a lot there. It was quite a rigorous system, but we learned a lot there. A lot of clinical exposure. Early career took me back to Namibia. Worked at a place called Katutura Hospital, sort of on the outskirts, close to the largest area. It's called the township, Katutura. But it was quite close to where we actually grew up, which was on the outskirts, in the Komos Hoogland, in the mountains, and there was certainly a good rural feel. This was the time of 86, 87, and we know Ian's history and Steve's history. I was also conscientious objector, didn't want to join the war, and this gave me the opportunity to firstly work in public health. This was also the time of when HIV started, and they employed me in a very nice position called the director of the Namibian HIV/AIDS awareness campaign. I worked with clinical epidemiology, primary healthcare preventive levels, expanded program of immunizations, the TB control program, and also a lot in health system and support. And what was, to me, very attractive about this job was not being in the office, but then it was not about being attractive as a conscientious objector, but it took me to very nice parts of the country as well. And I was in contact with people who worked in these areas. Some of you may know these places. They've got wonderful names: Okakarara, Korichas, Opool. This is Kaokoland. This is wild desert. This is where the frontiers are. There was, however, this Namibian system was fragmented as well. They didn't have their sort of area called the Kavango area and area, and there was then the sort of more centralized area. That is where I was involved with. But they were worried about some of these. They were not quite Bantustans, but they were regional areas, and they were allocated to particular areas. That there wasn't a good mix between the efforts in the Ministry of Health and what happened in these regional areas. And they were particularly worried about an area called the Kavango area. And then I had the privilege to go there. Now, the Okavango is a beautiful area. It's a wonderful ecosystem. It's a river that starts in the highlands of Angola. It goes to the northeastern boundary of Namibia, between Namibia and Angola, for about 400 kilometers, and then ends in Botswana. This river system is threatened by climate change. It's something that we were not fully aware of in 1988 and 1989. It's a major issue now. Also want you to think there's another word, a concept, that of a boundary or border. There's this idea of border between Namibia and Angola. Also, the Namibian War of Independence was also called the Border War, Grensoorlog. I want you to think about this word border. It will come up again. Okay, running of a rural hospital, I think many of you may be used to this. In Rundu, it was very much male ward, female ward, pediatrics, psychiatric service, and then primary health care was parked somewhere outside of the hospital. Why this is important? Because this was extremely important for my own training. I spent a lot of time in pediatrics, so a lot of obs and gynae, anesthetics as well, but at the same time I was sort of tasked to look at primary health care, preventive care, public health. And the feeder hospitals along the Okavango River, about 10 to the west of Rundu and about 10 to the east of us, they're mainly clinics, but there are 4 hospitals. At one stage, these were serviced by doctors who would drive out on a mobile. And when I was there, the doctors basically felt it was too busy a hospital. They didn't want to do this. But this conscientious objector, he was a good guy to go out to the clinic. And I must confess, I actually quite enjoyed it. So I was going out in the car, I got to know all the people, and then that is the beauty of knowing people. I think we've heard this a lot. To understand context, to then think about referral systems, communication. And again, it needs to be said, there was a lot of mistrust. This was a time of a border war. There were different political factions, and then this was a difficult time with regards to that. I was very privileged to have my good wife Ulrika with me. She was an occupational therapist. As she arrived in Rundu, she heard that there was no physiotherapist, so she was lone OT, lone physio, working with 2 assistants for the entire area of 300,000 people, and to service all the needs, including a lot of CP, and then all sort of problems. I mean, you don't need to be introduced to those, but that was tough. She had a special love for pediatrics, and I think actually applied as well as she could many of the principles that were discussed for CP this morning. But it's a lonely ship out there if you're on your own. So yeah, these are images that you will all know from sort of clinics, from people living along rivers. I learned a lot from the healthcare providers in the area. I learned a lot about malaria prevention. I also enjoyed some of the nice nature, some nice animals, area called Babwata National Park, especially the Mahangu section, which was just to the southwestern side of the Kavango River. And then I also learned about some of these traditional, almost biblical diseases, leprosy, and we also looked after TBs. The leprosy service and the TB service was a nurse-run service, mainly, and I was fortunate to learn a lot from them, and then to provide more than just medication and a diagnostic service, but actually to care for these patients. And that was very nice to integrate that with the community and primary healthcare efforts. There were important people, and I think this is an important topic of my talk, is this, the people that influence you, the people that have major impacts. And this lady, Dr. Libertina Matila, was one of these very, very special people. Now, she grew up in a very rural place called Korrigas. She went to school in Korrigas. She walked out of Namibia. via Zambia to Tanzania to train overseas. And she then returned at the time of the liberation of Namibia and became the first Minister of Health. We really got on well. She was lovely. She came to visit, and there was a really special time to spend time with her also in Rundu, and she did some of these visits with me to the clinics. This was a minister who's actually interested in the clinics and what was happening on the ground. Yeah, I think the idea to strengthen primary healthcare did happen. I think I had little role to play in that, but there was some facilitation. And again, the importance was the communication to the Ministry of Health. That was connected. So by having a person who understood what worked in Windhoek and who understood what was happening on the ground in that part of Namibia, that was helpful. And through that, I think very useful structures could be established, and it was a program, I think. And then I think many of them are not still there. I mean, it was good and it was wonderful. I'm not there. And that's a difficult time. It was a difficult time. It was a time when the ministry then decided that Rundu was too big to be run by family medicine, or so they really, and they couldn't find the doctors. Maybe it's important to know that, but in a period of about 18 months, the number of doctors who'd worked in the south of Angola and that part of Namibia was diminished from about 30 doctors to about 3 doctors. The patient numbers had increased because a lot of people had actually then moved from the southern part of Angola to Namibia to access health services. So this was difficult. This was a difficult time. And then through the United Nations Development Program, WHO, posts were created, but they couldn't find generalists to fill these posts. So they filled posts with specialists in obstetrics and pediatrics and internal medicine. I think it was good for the hospital. I think it's the only reason why I could leave, but it was not good for the integration with the referral hospitals and clinics. Okay, I then went very different direction. I studied medicine. I went to Cambridge, and I went to Norwich, and I was at London School, and I was very fortunate that I got one of the first training posts in HIV medicine. It was pulmonology HIV post, and we saw Cytovidine, or AZT as we know it. I think we were probably the first hospital in England that actually did dual therapy, DDI, AZT. And then interesting enough, we saw one single case of pulmonary TB, mycobacterium tuberculosis, in a 1-year period. It was not the disease that it was known for. We didn't see children. We saw hardly any women. And then maybe this is something to just reflect on. And this was an HIV ward runner. This was a special unit. But there were about 14 different people, social workers, dietitians, nicely interprofessional. But we saw about 3 patients and we had about 4. Okay, and then I decided, okay, no, this doesn't quite work. In Rundu, for 300,000 patients, 3 doctors. Here for 3 patients, 14 health professionals. Doesn't sound quite right. The politics also worked out. It was possible to actually return for me to South Africa, and we did that. And I then, being in medicine, got a job at Tygerberg and worked mainly infectious diseases, and then, interesting enough, cardiology and rheumatology. We had to expand training in HIV medicine. This is a group of young doctors you may know, Anneke Hesling, Ben Murray, Yankee Talyat, who's been mentioned, who joined us to the National Institutes of Health to undergo training that was sponsored by the International Society for Infectious Diseases. My interest then became a disease of poverty. We call it TB, specifically pericardial tuberculosis. This was a common cause of cardiac failure, also in the Eastern Cape. At one stage, this was known as the Transkei heart. It's like the Mussolini hip. There was a Transkei heart, and Transkei heart was actually constrictive pericarditis due to tuberculosis. Most common cause of cardiac failure in that area. Now, TB pericarditis can be difficult to diagnose. You can use interferon gamma assays and ADAs. We said make it simple, and we developed what we call the work diagnostic score, which looked at weight loss, night sweats, fever, a certain globulin level, leukocyte count in a person from an area where TB occurred commonly and had a pericardial effusion. We took the TB work further with Bongani Mayosi to one of the largest trials on tuberculous pericarditis. And this was on a little shoestring budget across, I think we were literally for that study, 8 African countries, many patients from rural areas looking at outcomes, TB pericarditis, and used that particular diagnostic index for enrollment of these patients. Bongani is unfortunately not with us any longer. He was a wonderful friend, he was a wonderful scientist, and he cared from rural areas. The other wonderful thing that happened is, again, by invitation of my brother, Lusiki Siki. Now, Lusiki Siki sounds lovely. You hear the wind rattling in the breeze. Lusiki Siki, 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 Siki. Okay, it wasn't all romantic, Lusiki Siki, that I can tell you. But we're coming now to this MSF, Médecins Sans Frontières, without borders. Without borders. And I want to really make you think about the concept of that we should not think in terms of boundaries and borders, but beyond borders. The ARV program was completely community-based. It was run by community workers, many of them patients living with HIV. And the importance is that the enrollment numbers for patients on ARVs was much better in the community where there were no doctors involved, maybe a driver called Herman, and compared to the hospital where there are 3 or 4 doctors involved. This was at a time when in South Africa it was believed that HIV didn't really exist, that ARVs needed to be handed out in specialized infectious diseases centers. And here came a study which showed very clearly it can be done in the community, it can be done in a rural area, and you don't need to train people, but you need very dedicated people. Madiba loved this program. He came to Lusiki Siki at regular intervals. He got hope from the CRP Lala means we are alive. The HIV positive we see here today are alive. They are healthy and they are happy. What we see is proof that there is life after HIV/AIDS. Let's together to send that message to communities across Africa and around the world. This was December 2003. I think there are many important lessons, but the most important lesson is that decentralized work worked and that there should be high community participation. About the same time, Ukwanda Center was initiated. Etienne van der Walt was actually the first person. He conceptualized the Ukwanda Center. I was part of that. He negotiated, he communicated a lot with, I know with Ian as well to get a concept for the Ukwanda Center. And then at the end of 2002, they asked me to take that program forward. I started in office with Helene van der Walt, who was already the PA of Etienne. And then we got Jill Fortuin. She was the telemedicine coordinator. Now, again, many people will not understand that in 2002, we didn't know Zoom, we didn't know MS Teams, we didn't know WhatsApp, we didn't know Wi-Fi. So to be a telemedicine and telehealth coordinator in 2002 was a very different game from now. Then Hoffi Conradi was family physician in Worcester. He then took over from me after 5 years. And then Lindsay. Lindsay was one of the first people we appointed to look at the logistics, getting the students safely. Denise was also logistics. Colleen, who's still in Worcester, was the person who recruited in Worcester. And then Emil Reed, he was infectious diseases. colleague. He was very much involved with the elective module, and the elective module was for us a way how we got many undergraduate students to go to the Eastern Cape and other areas, KZN and Eastern Cape specifically for rural elective. And then Ben Murray, he was a pediatrician who did a lot of work also in the province for the maintenance of competence project and evaluation of what was happening on the platform. I think we've heard all this and you've seen the results of it, so I don't need to say too much about that. I think you may have heard about the hub and spoke model. This was with Worcester as a center, and then how this was run around family medicine, but it was always interdisciplinary, was always interprofessional. I think that was very important, that everything that we did was for all health professions in principle. I think the Avian Park Service Learning Center started very simple, but there was a very early success. This is very much due to Hofi Conradi, who believed very strongly in providing services in the community and making sure that students went to the community, experienced community, lived community, and then in that context provided healthcare. Yeah, I think there are lots of beautiful pictures, a lot of reflection. And then, of course, we also needed to write up some of that, of the things that were happening. This was before there was a Center for Health Professional Education. And it was good. There were good people who started asking the questions, doing qualitative research. There was some quantitative research. It was published. We did a paper, intervention for increasing the proportion of health professionals. This has now been cited 521 times. Some of you may have actually cited this paper. And I think this was a very nice collaboration for health equity through education and research. I think this was actually Steve's baby to a large degree, but this brought a lot of us together. At that stage, Steve was at UKZN, Ian was at WITS, I was at Uganda, Jimmy Volmink was in primary healthcare at UCT, and this has been a very important area again of collaboration. And there was, as I say, at that stage we couldn't just team or Zoom, but actually bringing the people together who felt for health equity and who also believed that there was a role in education, but that needed to link to research, and that they should not be separated. Equity, education, and research belong together. Yes, from the Uganda Center, then went forward to formalizing the Uganda Rural Clinical School. This was I was not responsible for creating it, but I wrote a paper on how I conceptualized this part from the center to the school. I started looking for some funding, and we're very, very fortunate that the late rector, Vice Chancellor, Russell Botman, he bought into this concept completely. Hope Project, and through the Hope Project, that made a major difference, that Stellenbosch University committed as a university completely equity through education and research in the rural platform for rural and underserved communities. On the way here, I quickly took photos. Now we're back to the brick and mortar. I think you've seen the wonderful work that Franco is doing, that Amanda is doing, to know that it's not about the brick and mortars, but it's nice to have that as well. So yes, there's a beautiful school, but it's the people that make it, it's the students that make it, it's the communities that make it. And as it was with CHIA, we all belong together. We all need to do this together. So now the question, where does this medicine story then come in? Okay, from the single track, I've now got a mishmash of roots: public health, primary health, tropical medicine, mother and child care, psychiatry. I've worked a bit in all of those. You will see there's no subspecialties on here. There's not the typical medicine, cardiology, pulmonology, nephrology. This is what medicine is all about. And what I've decided, where I can play a role in all the students from the medicine program to the rural areas, but I can bring the concepts in the context of rural areas into the medicine ward round. And I think that is what we're doing. I try to influence as many as possible from early undergraduate days to the registrars. To whenever they present a patient, they may never not think about where's this patient from, Where's this patient going to? What are the referral pathways, and how do we need to communicate that? And I think that is the wonderful journey that I've had to now be able to actually bring the rural context into the hospital next to the patients, the bedside, and that we don't lecture from the bottom of the bed, but we speak to the patient, and we never start a ward round without knowing where a patient has come from and what their background is. Thank you very much indeed.
I'm really happy that your brother persuaded you to come and speak. We're a little bit over time, but are there any questions or comments that anyone wants to make? We ran a tutorial at Kritskier with patients in a tertiary hospital, and it's called Uvelaphi. Where do you come from? Because I agree with you, you have to start, wherever you are, you have to start with that question. Where do you come from, and what is it like there? And what are the issues that made you so ill as to be admitted to a hospital in that environment? Yeah. Anybody else? Yes. Behind you.
Thank you. I'd just like to thank you for crossing the boundaries and undermining in a very practical way. Well, I guess it draw from your experience and your journey, but the divide in the dichotomy between specializing and caring about general medicine, community healthcare, and rural focus. And please don't die anytime soon.
Yeah, I think the dichotomy and the ambivalence go together, that we need to have specialist skills, we need to have special knowledge, but I think it's about integrating what we know, what others know, and always respecting that and making it part of the larger whole, and then that we learn the skills because they're good to have, but that we never think that a particular skill is superior to other skills, and then that we always look at interprofessionality and collaboration, working together, and putting the patient and the family first, and then health systems and politics, unfortunately, do play a role.
Yes, Francois. I know we're going to lunchtime, but this is worth it.
So on the note of where you come from matters, I want to know all the guys that was mentioned with the initiation of Okwanda. Can you tell us where they all originated from? Do you know? No, just like because I think it's relevant.
The people who worked on the program.
Yeah, or initiated the program, like you and Bonnie. All the major stakeholders that were part of the journey. Yeah. So some of like Ben Maria, is he from?
Ben Maria, I think, actually came from Oudtshoorn.
Yeah. I think it's relevant.
I was almost caught out here. Yeah. Just imagine, as I asked my colleague, my patients, where they come from. I didn't know where my colleague is from.
Yeah. And Prof. Hoffy, where was he from originally?
Okay, so Prof. Hoffy, I mean, his family history came from Stellenbosch, but he was from Dordrecht. That is where he really learned his skill as a family physician, was in the Eastern Cape in Dordrecht. And my Yossi was from the Eastern Cape. Yeah, he studied at UKZN, but his heart was in the Eastern Cape. Also, when he started in Cape Town, the first area where he worked in was in the township. Immediately he went to Langa and said, we need to do something. And he wanted to look after patients that came from the Eastern Cape in the setting of Langa.
I just wanted to ask because I think it's relevant in part of our context in rural roots. Yeah, and just to note something on Ben's. So my father used to teach with Ben's father. He used to be the headmaster of the school I attended. Yeah. So I sort of know. I knew the history. I'm I'm fairly younger than Ben, but there's always been sort of a thread there. I think that's important to note. It's just tying it to the initial discussions where we started recruiting from rural spaces and just the impact that people that come from rural settings can actually have in healthcare. And I'm also highlighting it for the younger students that's sitting behind me. Just to note, guys, 20, 30 years time, it's your time. Or before that.
Yeah, so maybe we should put more attention into selection policies and criteria and forget about the fancy curricula. Just select the right students and then the rest will happen. Amanda?
Thank you very much, Dr. Ritter. I actually would like to say, your brother asked me when I met him, I said, your reputation precedes you. And he said to me, I hope you're not confusing me with your brother. And now the connection has happened. I'm from the Sigi, and I once visited him in embassy building where his office was, because at the time, every time I came home from holidays, my mom had a line of children for me to see. And I was still a student. And I came to him to ask, could they do an outreach in my area, which was Egoso. And he said, we already have people there. But I mean, I remember how difficult things were in the Sigi during that time. And as much as the wind blows the reeds, it is a troubled community. And it still continues. And I think that's probably where I'm encouraged when I see this, because then you understand who you are, whose footsteps you are following in, and you understand the vision, and it's really exciting. Thank you.
So thank you, Helmut, for making the connections. Thank you, Hammond, for making the connections. Thank you, everybody, for being here, and a really stimulating session. Enjoy your lunch.